Good afternoon and hello everyone. Welcome to today's event, Innovating with Telepsychiatry to Improve Mental Health Care in Health Centers webinar, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist placed in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event with my division colleague, Don Weaver, the Senior Advisor of the Clinical Workforce. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. Again, you have either joined this event by either physically calling in or using computer audio. All attendee lines have been automatically muted for the duration of this event. The duration of this event is approximately 60 minutes, including introductions, presentations, and Q&A. Throughout today's session, the Q&A box will be available for your comments, questions, or concerns. You can find the Q&A box located in the lower right-hand side of your computer screen. Simply type your question, select Send to all panelists, and hit the Submit button. Again, this Q&A box will be available for the duration of today's event, so type your questions into this box. Make sure you hit to send to all panelists and make sure you hit the send button. Do not send privately. All of our panelists will see your questions throughout today's webinar. We'll take periodic pauses between each session to answer a few questions as well as some of the questions that you submitted in advance. And we will also have a live Q&A section at the end of today's session today. Any questions that we cannot answer in the time allotted or that need further clarification will be made in an attempt after the webinar is complete. Friendly reminders that today's event is being recorded and will be available post-event being completed online. All attendee lines have been automatically muted and will be muted for the duration of this event. Q&A box is open for the duration of this event. Please type your comments, questions, and concerns into this box at any time. And at the end of today's event, you'll be presented with a brief 4-question survey. This survey lets us know how we did, how valuable this event was to you, and directly informs us of future training and technical assistance. We value your feedback and encourage you to complete this survey. At this time, I'm going to turn things over to Don, who will be introducing today's speaker and giving us a lay of the land of what to expect today. Don?
Thanks, Elizabeth. My name's Don Weaver. I'm the Senior Advisor for Clinical Workforce at NAC. I want to begin by thanking each of you for the amazing work you're doing in your communities to address the COVID-19 pandemic and for joining us today for Innovating with Telepsychiatry to Improve Mental Health Care in Health Centers. This webinar is based on SPIRIT, the Study to Promote Innovation in Rural Integrated Telepsychiatry project. But SPIRIT is an interesting acronym, but it's also, I think, reflects the enthusiasm of the participants. The University of Washington received funding from PCORI, the Patient-Centered Outcomes Research Institute, for this project. And while the focus was rural, and rural health centers specifically, we believe you will agree in this age of increasing use of telehealth, there's relevance for all health centers, whether they are frontier, rural, or urban. Most importantly, this project demonstrates how health equity and the quadruple aim can be addressed when a committed university, health centers, and their primary care associations partner. Our 3 presenters represent this partnership. Our first presenter is Professor Dr. John Fortney, Director, Division of Population Health, Department of Psychiatry and Behavioral Sciences, University of Washington in Seattle, and the Principal Investigator of SPIRIT. John?
Yes, thank you, Don. The next slide. So I'm going to be talking today about our quantitative findings from the SPIRIT trial. Next slide. But let me start out a little bit about some of the epidemiology. SPIRIT was designed to improve the outcomes of patients with more complex psychiatric disorders, specifically PTSD and bipolar disorder. The prevalence of PTSD in health centers is about 20%, so the prevalence is quite high, though it often goes undetected. And it's highly comorbid with depressions. About 85% of the patients with PTSD also have depression, and that probably does go detected to your PHQ-9 screening. Interestingly, only about a quarter of patients nationally with PTSD see a mental health specialist during the course of a year, and only 23% see a psychiatrist. So they're presenting to primary care, where kind of across the board, the quality of detection and treatment is a problem. Only 15% of patients with a PTSD diagnosis have a documented diagnosis in their medical. They get diagnosed and treated. And taking just an antidepressant for bipolar disorder is contraindicated, so it's poor quality care. Again, about 24% of patients who screen positive for depression have bipolar disorder, and we have found that of FQHC patients screening positive on the PHQ-9, about 30% have bipolar disorder. Similar story, only about a quarter of patients with bipolar disorder nationally get to specialty mental health in the course of a year. And the quality of detection and treatment of primary care is poor. One study found 0 patients screening positive for bipolar disorder had a diagnosis documented in their medical record. And when they do get diagnosed, it's usually 6 to 8 years between onset and diagnosis. And again, the quality of treatment in primary care tends to be poor. One study found 72% received inappropriate medication, meaning an antidepressant alone, without a mood stabilizer, and 18% received no medication at all. So this is a problem that we're trying to solve. Next slide. There are highly effective treatments for PTSD and bipolar disorder, both medications and psychotherapy, but health center patients don't have access to these treatments. Nationwide, there's only one psychiatrist per about 50,000 community health center patients and one psychologist per 43,000 patients. So what traditionally happens is a health center PCP will refer a patient out to a specialty mental health setting, such as a community mental health center. And as many of you probably already know, that often doesn't work out. So a large proportion, usually about 75% of patients referred to specialty mental health aren't successfully referred. They don't make it. They're unable to engage in that referral treatment through either the travel distance is too long, the cost is too high, the wait time for appointments is too long, or it's stigmatizing, or all of the above. And they tend to get then treated exclusively in primary care, often where they just get prescribed medications for depression. So health center providers are increasingly challenged by these patients. They feel, through qualitative interviews we've done with the providers, they tell us they feel obligated to treat these patients, but unprepared and unresourced to do so. So that's the problem that Spirit was trying to solve. Next slide, please. So there's 2 potential solutions that we compared to see which worked better. The first we're calling telepsychiatry enhanced referral care. And that's where instead of sending a patient out to the mental health care system, the mental health care system comes to you over interactive video. And what we did is have the health centers participating in the Spirit trial partner with their state's medical school to provide those telepsychiatrists and telepsychologists. And we wanted to avoid having the patients enroll in the state medical school healthcare system because that's a logistical challenge and it can be stigmatizing for patients. So instead, all the telepsychiatrists and telepsychologists participating in Spirit were privileged and credentialed to practice as a health center provider. So there was a contract set up between the health center and the medical school. They were given remote access to the EHR. The health center purchased supplemental indemnity coverage to cover malpractice for those providers or for their setting. Providers got insurance credentialing so that a health center could bill. And in most cases, the health centers had to expand their scope of project to include psychiatry. In this model, the telepsychiatrist takes over the prescribing for the patient. They prescribe through the EHR, and the telepsychologist delivers psychotherapy. So for PTSD, we delivered trauma-focused psychotherapy called cognitive processing therapy, and for bipolar disorder, we delivered cognitive behavioral therapy. The other model is an integrated care model, similar but somewhat different from the Cherokee model that you may be more familiar with. It's called collaborative care. In this case, it was telepsychiatry collaborative care. And this is a team-based model. The primary care provider does all the prescribing, but they're supported by a behavioral care manager and by a telepsychiatrist. So the telepsychiatrist will see the patient once, assign a diagnosis, and then recommend medications for the primary care provider to prescribe. This is a very patient-centered model. The care manager educates patients about treatment options, assesses their preferences, engages in shared decision-making to choose a preferred treatment. They monitor and manage their side effects. It's also a measurement-based care model where they're using instruments like the PHQ-9 to track symptoms at each encounter and determine whether treatments are working or not. It's a population-based model whereby every patient is added to a registry and not forgotten about. So whenever the care manager meets with a telepsychiatrist to go over their cases, they also talk about patients who aren't engaging in care and come up with plans to re-engage them so patients don't fall through the cracks. And it's an evidence-based model. So the telepsychiatrist is making sure that they're providing recommendations to the primary care provider based on the latest evidence, and the care manager is trained in a brief counseling called behavioral activation. Next slide. So we did the Spirit trial in 3 states, Washington, Michigan, Arkansas. There were 12 healthcare center systems with 24 clinics. The study was done between 2016 and 2020. All patients screening positive on the PHQ-9 for depression were also screened for bipolar disorder and PTSD, so it was almost universal screening. We had about 3,000 patients screened positive, a third of those for bipolar disorder, and the rest for PTSD. We excluded patients, about 18% of those screening positive, who were already getting psychotropic medications prescribed by psychiatrists because they didn't need this additional care. And we ended up consenting, enrolling, and randomizing over 1,000 patients. And so we randomized each patient consented to a telepsychiatry collaborative care or telepsychiatry enhanced referral. Every patient, we did a survey with them as soon as they enrolled at baseline and 6 and 12 months later to see whether their symptoms were improving. Next slide. In terms of the characteristics of the patients enrolled, this should look familiar to you guys. There was a lot of racial ethnic diversity. 2/3 of the patients were living in poverty. 2/3 of the patients were covered by Medicaid. Another 24% were covered by Medicare, and about 7% were uninsured. Only about 19% were employed full-time, another 12% part-time, so most patients were unemployed or retired or students. Next slide. The screeners did pretty well. On the top left here, you can see that when the patient did see a telepsychiatrist and got a diagnosis, those that had screened positive for PTSD were actually diagnosed with PTSD 76% of the time, which is a very low false positive rate for the screener. And for bipolar disorder, which is much harder to screen for and diagnose for that matter, we did pretty well, I think. 44% of those screening positive bipolar disorder eventually got the diagnosis. There was also a lot of what we call comorbid psychiatric diagnoses. So 60% also were diagnosed with depression, 37% also diagnosed with generalized anxiety disorder, and 13 and 14% with alcohol use and drug use disorder, respectively. Next slide. So the left-hand part of this screen shows engagement in the telepsychiatry collaborative care model. So the first bar there shows what percentage of patients had a encounter with their care manager, and the health centers did a great job with this. This was 92% of the patients ended up seeing a care manager. And then on average of those who did, they had 10 care manager encounters over the course of their treatment episode. So they're getting a lot of care. And as designed, most patients also got to see the telepsychiatry consultants to make sure that the diagnosis was right. So 75% of patients in the collaborative care model saw their psychiatrist, and on average there was 1.4 consultation visits per patient, kind of as designed. So I can expect that when you refer patients out to see a psychiatrist, you're not getting 75% of them to actually show up for the appointment, and that's what this kind of integrated care model is able to do. On the right-hand side, it shows the telepsychiatry enhanced referral arm. Those referrals were also very successful compared to what we typically see, a little bit higher. 78% of those patients saw a telepsychiatrist, and of those who did, they had about 4.3 visits over the course of their treatment episode, and about almost 50% also saw a telepsychologist, and those who did, they had 6.3 counseling sessions. So really good engagement and care in this trial with these two approaches. Next slide. Next slide, please. Yep. So this shows how much of this kind of scarce mental health specialist resource was used by each model. So on the left-hand side, you can see of all the patients randomized to the telepsychiatry collaborative care, they had on average one visit with the telepsychiatrist. So their care involved one visit in total. In comparison, in the telepsychiatry enhanced referral arm on the right-hand side, they had over 6 visits of patients randomized to this model. They had over six visits with a telepsychiatrist or telepsychologist. So this model is using 6 times more mental health specialty visits, presumably costs that much more, 6 times more as well. So it's using a lot more resources that are scarce. Next slide, please. So the next couple of slides are going to show what our outcomes were, our clinical outcomes. We did these 3 surveys, one with 0 or baseline, one at 6 months, and one 12 months later. And this particular outcome is called mental health functioning. The science term is SF-12 mental health component summary score. And on the average American scores about a 50 on this instrument. And you could see at baseline the health center patients that enrolled in our trial were scoring about a 27, which is about 2.5 standard deviations below the national mean. But the good news, the dotted line is the collaborative care arm, and the solid line is the referral arm. And the good news is that patients in both groups had substantially and statistically significant improvements in their mental health functioning over time. This is, compared to other studies, this is a very large improvement in how people are functioning. Next slide. And then looking specifically at PTSD symptoms, this is measured using something called the PCL-5. Patients were starting out moderately severe at about a 50 in both groups, and both groups showed substantial and statistically significant decreases in PTSD symptom severity, about 17 points. Again, that's a clinically meaningful improvement, and going from moderately severe to kind of more not nearly as severe. Next slide. This shows the proportion of patients who are euthymic. Euthymic, this is just for patients who were screened positive for bipolar disorder. People with bipolar disorder tend to have 4 mood states. They're either manic, they're depressed, they have a mixed state where they're both manic and depressed alternatively, and then they have euthymic, which means they're neither manic nor depressed. So you want to be euthymic. For patients at baseline, only about 10% were in that mood state, and by 12 months, almost 30% in both groups were in that mood state. So that's a huge improvement in the mood stability of the patients with bipolar disorder. Next slide, please. These are depression symptoms. measured with something called the Hopkins Symptom Checklist, similar to the PTSD. They started out moderately severe and decreased substantially and statistically significantly over time. Next slide, please. This is the same thing except for generalized anxiety disorder, measured with a GAD-7. They showed substantial improvements in their anxiety symptoms as well, which is often a comorbid problem that these patients have. Next slide, please. And we got a lot of patients to begin medications, initiate medications, or switch medications in both groups. And one thing we were concerned about is, are we increasing people's side effects? Well, when the people started at baseline, they were reporting to us that they had 4 side effects from these psychotropic medications on average. And by 6 and 12 months later, that number of side effects that people were reporting was reduced. So by 12 months, it's down to 3. So we're getting more people on medications, but they were having fewer side effects. So that shows really good medication management. Next slide, please. So just to conclude, we found no differences between the telepsychiatry collaborative care and telepsychiatry enhanced referral arms of the study. Patients did equally well in both groups. We saw improvements in mental health functioning and decreases in their PTSD symptoms, bipolar symptoms, depression symptoms, anxiety symptoms, and side effects. And so, to me, the overall conclusion here is that the integrated care model, telepsychiatry collaborative care, can generate similarly good outcomes as the referral model with only 1/6 the amount of telepsychiatry, telepsychology time. And that is the end. Next slide, we can see if there are any questions.
Thank you very much, John. And we did have a question that was sent in advance, and it's, how do you deal with no-shows for psychiatry appointments, which tend to be much longer than non-mental health medical appointments, especially for telehealth visits?
So this is a fantastic question, and if you could advance to the next slide, I can show you that it indeed was a problem. So these are our 12 health centers, and the no-show rates varied from health center to health center, but were, pretty high. They're about, 25%. And this is important because when you contract with the state medical school, you're probably going to be buying like a fixed number of hours of telepsychiatrist time per month. And if the patient doesn't show, you still have to pay for that time, but you can't bill the insurance company for it. So it's not revenue generating, so you lose money. And part of the problem is that the state medical school, the psychiatrists there or the psychologists are going to want to block off specific times for appointments. They're at the same time each week. So let's say they do Thursday morning from 9 to 12 is when they provide care. And so that doesn't provide a lot of flexibility in terms of when patients can show up for the appointment. So it creates, I think, an issue in addition to the long appointments, and they tend to be frequent appointments. It creates a problem with no-shows. As you can see, there's variation in the health centers across this, from high of 50% no-show rate to low as 15%. And I think that reflects both differences in patients perhaps, but also differences in the way the health centers were able to mitigate the problem of no-shows. And so the health centers that did well were, sending out lots of reminders to patients, maybe providing transportation, putting limits on how many no-shows that each patient could have. And one other thing that we didn't do that I think would work well is to, have a bit of an open access clinic. So if a patient is scheduled to see the psychiatrist and they don't show up, you find somebody else in the clinic who would benefit from seeing the psychiatrist that day. Chances are there would be somebody at that clinic. So that's a really good question and something we've struggled with.
Thanks, John. Are there any other questions which you can put in the Q&A section? And we will also have time at the end for sort of general questions of each of the providers. So I think the operative question is, seeing none in the Q&A section, I'll thank you again, John, and move to our second presenter.
John?
Oh, I'm sorry.
John, it looks like there is a question from Nelson. If you scroll all the way to the bottom of the Q&A.
Okay. Well, my scrolling. Well, wait a minute. Maybe I did get. Could you read the question to us, Elizabeth?
Sure.
Thank you.
Looks like. Did you buy an EMR license for each one of the psychiatric medical residents involved in the project?
I'm sorry, could you repeat that?
Sure, John, now that I've got it.
You got it? Okay.
Well, did you buy individual EHR licenses for each of the participating psychiatrists and psychologists that were at the university?
Yes, and that was expensive. That was a problem.
Did that answer the? I guess we did.
I think that was all of the questions.
So I think if anybody else had any questions, folks, if you logged in late, the Q&A box is available. It's located in the lower right-hand side of your computer screen. Feel free to type your questions at any time during any of these presentations. We'll be breaking periodically for Q&A, and then we have Q&A at the end of all of the sessions today. So, Don, the floor is yours again.
Thanks, Elizabeth. Our second presenter is Dr. Susan Ward-Jones. She serves as the Chief Executive Officer of East Arkansas Family Health Center. Susan, I will turn it over to you.
All right. Thank you so much, Don. Next slide. So, innovating with telepsychiatry to improve mental health care in health centers. Next slide, please. So I thought that it was best that we kind of tell you who we are and where we are. We're located in Arkansas in the heart of the Mississippi Delta. We have 18,590 users, representing some 75,000 encounters. We cover 4 areas: Crittenden, Poinsett, Mississippi, and Phillips County. Our main site is located just 10 minutes from downtown Memphis, just separated by the Mississippi Bridge. We have 7 healthcare delivery sites, 3 school-based health centers, 1 admin site with HIV/AIDS case management. We've been Joint Commission accredited since 1997, one of 2 health centers in the state, NCQA PCMH Level 3, and we've been a HRSA Quality Healthcare Leader since 2016 with an annual budget of $20 million. You can see our patient demographics. The preponderance are female at 62%, our age 18 to 64 years at 66%, insurance uninsured rate of 26%. Prior to the implementation of the Affordable Care Act in 2014, our uninsured rate hovered around 65%. You can see insured is now 74%, with Medicaid representing our largest payer at 35%. Our race includes 64% Black or African American, with white at 33%. Next slide, please. So our staff. We have a diverse staff with providers that include physicians, a pediatrician, ophthalmologist, nurse practitioners, including a psychiatric nurse practitioner, 1 physician's assistant, LCSW, 7 dentists, a hygienist, a pharmacist, diabetes educator, also case managers, and we have a clinical informatics nurse that we're so pleased with in terms of helping us to know our data, particularly when it comes to UDS. And we also have employed an RN contact tracer during this COVID pandemic. We have 10 referral specialists, care coordinators, health worker, health navigator, and our services include primary care and all the normal services that health centers have. And we're most proud also of our ability to take care of HIV/AIDS clients in in-house lab and x-ray. And we have 2 in-house pharmacies and just recently opened a retail pharmacy. We provide all of our transportation for our patients for primary care and specialty care. And we're most proud also of our mobile medical clinic where we'll take care to the public. And it made its debut last night in the annual Christmas parade. Next slide, please. So I thought we should start in terms of how we established our behavioral health program. And we've had a long collaboration with Dr. Fortney, whom you just heard from, and also with UAMS. We first started with a depression outreach study in 2006 to 2011, where we utilized the collaborative care model, where it really focused on increased awareness of high prevalence of undetected depression, and also there was some concern from that study about bipolar disease. We were then involved in 2010 to 2015 in the RISP study looking at bipolar and alcohol with Dr. Fortney and University of Arkansas for Medical Sciences, where we were more aware of undetected bipolar disorder with sustained adoption of bipolar screening and also the opportunity to publish in the scientific literature. Also, we were successful in getting the HRSA Mental Health Service Expansion Behavioral Health Integration Grant in 2012, along with the help from UAMS again, that provided us with the data about our patients who had participated in the previous studies and, really helped us to show the need for integration and also to develop an integrated program that was based on evidence-based treatments, and thus that led to the current SPEAR study from 2015 to 2020. Next slide, please. So our team, our behavioral health program consists of 3 LCSWs. We have case managers, which we refer to as case managers. We have a psychiatric nurse practitioner, and of course we utilize telepsychiatry with psychiatrists and psychologists. So of course the challenges, particularly in this study, was really kind of staff engagement. And of course when we have any kind of a new endeavor, you must have buy-in from staff versus it, being forced upon them. So we always like to make sure that staff are engaged in such a way that they buy in, and of course that sets the precedence for a successful outcome. Also, providers prescribing psychotropic drugs. Of course, we're not so familiar with that and don't feel so comfortable, but I will say with this study that we had much, lectures and scripts and things that would help us to feel comfortable with prescribing. And of course, also a challenge are workflow changes. But I will say that care managers were instrumental in reducing workflow challenges. And of course, when you have any change in workflow, it can be a challenge. Also, patient engagement was a challenge with, real apprehension about utilizing telehealth. And of course, we had to make them feel comfortable with that in a comfortable setting. Telepsychiatry providers, and of course, they have to actually enter the notes into the EMR, and sometimes there was a timeliness of entering the notes into the EMR. As we talked about before, the EMR provider license, we actually helped to negotiate a reduced fee for a part-time provider because the rates are so high. So that's a challenge as well. And also malpractice coverage. The health center had to take out a malpractice to cover the health center in case of any litigation. And also there was some difficulty with payers, particularly our Medicaid. Of course, Medicare, we could get reimbursed for the originating but not the distant. And our state Medicaid, we did not get any reimbursement. And of course, in Arkansas, patients only have 12 visits, primary care visits, and that includes behavioral health as well. So you can see the plethora of challenges that had to be worked through in making this successful. Next slide, please. So I thought it best that we look at some of the arm differences from a PCP perspective, the telepsychiatry collaborative care versus the enhanced referral. Of course, in the collaborative care, there was more PCP involvement and management. There was direct communication or communication via the care manager between the PCP and telepsychiatrists. With the enhanced referral, and it much operated like a traditional referral, that required less PCP oversight and was less time intensive. But the PCP experienced limited communication with the telepsychiatrist. Next slide, please. Also, another perspective in the arm differences with collaborative care. Of course, PCPs described increased medication prescribing and management skills, and I can say certainly that I benefited from that as well with consultation with the telepsychiatrist and getting comfortable in prescribing such meds. With the enhanced referral, of course, it operates like a traditional referral where the patients go straight to the psychiatrist or psychologist, and are started on medication, and then you see them back as you do in a normal referral pattern. So PCPs did not describe increased medication prescribing and management skills. Next slide, please. In terms of the patient perspective in the arm differences with collaborative care, and I will say the care managers, they are critical to mitigating barriers, patient barriers, and facilitating engagement. I will say in all of the practices, the care managers was the glue that kept us going with constant and frequent engagement with the patients. They facilitated discharge and transition to kind of usual care to come back to us, potentially better for patients that really kind of have difficulty opening up to new care providers and really kind of need a lot of touch points, and also most appropriate for patients needing an approachable kind of local contact as well. With the enhanced referral that operates, like a traditional referral, seem to be potentially better for patients who desire or require a higher level of therapy, specifically cognitive behavioral therapy or cognitive processing therapy, and those that, are open to standardized homework. So I think it's critical in trying to understand which would be better for the patient if there can be some choice. Next slide, please. And these are some direct quotes from some providers in terms of the arm differences, and this is from one provider when asked which approach worked better for them. They just simply stated that the TCC arm, in a sense, was more exciting because they were, their patients. With the collaborative care, they were seeing me regularly for medication refills, and then we had ready access to psychiatric care through the care manager, all-important care manager, to call down and see how the psychiatrist might suggest a change in medications and getting that occasional consult. With the enhanced referral arm, the patients kind of tended to sort of disappear into a black hole and get their psychiatric care for a year and didn't necessarily follow up with them. There was more interaction with the TCC. This provider stated that they really appreciated the collaborative care where he actually had more input and more feedback from patients. Next slide, please. The arm differences in terms of PCP skill and capacity, bipolar versus PTSD. One provider quoted, "I learned how underdiagnosed bipolar disease is," and that's certainly true, and I can testify to that. And I'm starting now to see that in several more patients where I probably would never even thought to look for it. This provider stated that it's opened up my eyes a huge amount to treating mental disease and looking for other diagnoses because bipolar is so hidden within depression. As far as PTSD, from a PCP perspective, one said that my prescribing practices now mimic the psychiatric consultant. He had a level of comfort where he would be more comfortable starting some medications for PTSD while trying to transition and get further help. Even just to simply try to recognize and diagnose is much more comfortable now. And I can say that, and there's a lot. Even one of the psychiatrists, quoted that health centers seem to have just a lot of PTSD. Next slide, please. And in terms of the patient perspective in the arm differences, one patient quoted, "I'm very forgetful. I forget about my appointments all the time." So the care manager, all-important care manager, would call, and ask me if I was going to be there and let me know ahead of time so I wouldn't miss. She was understanding if I missed and everything, so she was great. I can talk to her about everything. And I will say in terms of the no-shows, the care managers were instrumental in, making frequent touch points, and even to the day of if they missed, to call them to reschedule. And then just reminding patients that it's important for them to follow up with their mental health care just like they do for their hypertension and diabetes. One patient said, "I had the care manager's direct phone number. I knew I could call her, message her, whatever. I knew that she was there, so it was really easy to access that." Next slide, please. Another patient perspective in the arm differences. I think the biggest thing that helped me was the telepsychologist. She gave me homework to do, which made me have to pay attention to what I was doing every day, and I think that made a big difference. One patient said, I think they did a very good job. They helped me through a lot of things. I didn't realize what was going on with me. I would definitely give them an A+. Next slide, please. So some of the successes of the program, of course, enhanced access to meaningful psychiatric care, where we really, I think, improved health outcomes with patients in a way that we would have never known had we not been in the study. We learned best practices with telepsychiatry, from even just how to schedule that, and just improved real-time health outcomes. And what I mean by that is that you could see patients getting better before your eyes, and not even looking at any screenings, but you could see their disposition and move better, and even parlaying over into the medical practice, being more engaged with even just taking care of their diabetes. So it further exemplified the need for health centers to be involved in research opportunities and also in improved staff engagement. The sustainability, that all-important sustainability, and we've managed to, I think we'll manage to do that, with the continued partnership with the State Medical School, University of Arkansas for Medical Sciences, where we have contracts with the psychiatrists and psychologists to provide those services. There's a ready available workforce, and the cost is lower than private psychiatrists. There's an intact team in place with our psychiatric nurse practitioner, our LCSWs, and our all-important case managers, and then also administrative support and buy-in. And I happen to be the CEO, and also I continue to practice a couple of days a week, so East Arkansas will always have administrative support and buy-in. Next slide, please. I thought it important to really just show the improvement in remission rates, and particularly first with Arkansas sites. And you can see on the left with the collaborative care, on the right the telehealth referral. You can see pretty much the same in both arms in terms of improvement. A little bit difference in remission in both arms. You can see a little bit of difference in depression at 18% with the collaborative care and 10% with the telehealth referral. Conversely, remission was higher with the bipolar population at 29% with telehealth referral and 17% with collaborative care, and the same for PTSD in both arms. Next slide, please. Improvement and remission rates for all sites, as we stated before, was pretty much the same for the collaborative care and telehealth referral through all sites of Michigan, Arkansas, and Washington. Next slide, please. Conclusion, I can truly say, being involved in it from the outset, this study was designed with input from health center patients and providers. When you have input, and you can only be successful, it answers a policy-relevant question about whether treatment should be integrated or referred. It certainly met the clinical needs of our patients, providing meaningful access for our patients. I actually saw a patient yesterday that we needed to refer for depression, and she actually chose the enhanced referral for her care. Did not overly tax our health center resources. And matter of fact, we gained best practices and added resources for our health center. And I think that when health centers get involved in such studies, it demonstrates a level of excellence. And thus, we've been asked to be involved in another study, the STEP study, that will have comparative effectiveness PTSD trial of sequence, pharmacotherapy and psychotherapy in primary care. I'd like to think that we were asked to be in the study based on our past experience and performance. Next slide, please. And that's the end, and I'll entertain any questions if there are any.
Thank you so much, Susan. And if people would put their questions in the Q&A box, please? And if not, oh, I'm sorry. If not, we have time after the third presentation for some questions, so please continue to use the Q&A box. Again, thanks so much, Susan, for giving us the report from the front lines and what worked and what were challenges for you all and how you addressed those. Our third presenter is Jackie Chandler, the Integrated Health Program Manager from the Michigan Primary Care Association. Jackie, I'll turn it over to you.
Thank you so much, Don. We can go to the next slide. So I first just want to acknowledge, in talking about the path to sustainability, it's even just talking about the foundation of having something to sustain. And so I have to say that this work was only made possible because of the coordination and passion from University of Washington, University of Michigan with the Department of Psychiatry, many of my colleagues at the Michigan Primary Care Association, and of course, the intense efforts of 5 of our health centers. So that for me is important to say. Next slide. So what needs consideration? I'm really going to be echoing some of the previous statements that you've heard from John and Susan, because these things were very much felt and experienced in Michigan as well. And so I feel like that is a pretty good capture about how this is felt likely in other states around the country. So next slide. Actually, this one was going to be taken out. We had some incomplete data trends, but I did want to note, and I was kind of preparing for if I had left this one in here, when we did look at our UDS data for 2019, and we looked at FTE for psychiatrists in Michigan, we were less than 10 FTE in our state, and in the context of knowing that we served more than 711,000 lives in Michigan last year. So I just want to put that in perspective for how precious a resource psychiatry is and why it's so important to have this kind of study and these accessible forms of treatment. And so that's a really good backdrop. So this is a pretty naked slide because I didn't feel that we had good trend data to share at this point, but I'm glad that this one ended up staying in there. Next slide. Okay, so this has been covered by both John and Susan of, in order to invest in the true structure of this work, I mean, what we're talking about today is something that's different from usual care. So there are investments for the time. Even just credentialing and privileging a provider requires time and persistence, truly. You need to have buy-in from all levels of the organization. You need buy-in from leadership. You need buy-in from your board members. They might have to be adjusting bylaws. You need to be incorporating your HRSA project officer potentially if you're going to be looking at your scope of project. You also certainly need buy-in from your providers and from your care team members, because they might be feeling like if they weren't part of this process that it's yet another thing that you're placing into their laps with their feeling constraints from all around. And so really creating that buy-in so that this is actually something that is both serving the needs of the patients, because they're presenting to you with these needs and many are underdiagnosed, and that it's actually improving the job satisfaction and the performance of your team members, which, we all need that. And I think kind of echoes back to Don's previous statements around the quadruple aim. So again, this really was testing the differences for the hypotheses of the study versus usual care. And a big part of that is creating that actual infrastructure of having either directly employing or contracting with psychiatric providers, allowing them to have access to your EHR. So yes, it's very costly to have those site licenses for the EHR. And I can even note that one of our health centers changed their EHR during the course of the study. So yet again, had to go through that process of getting those site licenses for those providers. So we know that that is always going to be a present rub with this type of work. But We also know that in usual care, where you don't have enhanced referral or psychiatric consultants that are able to gain access to your EHR, what you typically have is you refer out to a specialist. You have a lot of delays in getting that communication feedback back from that specialty provider, and you often are not feeling very engaged in your patient's care. It certainly isn't feeling very integrated. And certainly with diagnoses such as depression or anxiety or bipolar disorder, that is absolutely having an effect on other parts of their care, whether that's diabetes or hypertension or COPD. So we all know that that's part of the adherence and the whole person care. So really being able to make these investments operational, and that's, kind of fronting that money to begin with. I could go on about this, but in the interest of time, I think we should go with the next slide. Some additional considerations. So yes, now you've kind of created your operational structure. Then there's some additional things to think about. So yes, we talked about constrained psychiatric providers. But again, is that psychiatrist comfortable with telemedicine? Are they versed in the collaborative care model to be a psychiatric consultant? So that's all kind of part of that choice of the contracting or the written agreements, whether that's with an individual private psychiatrist or if you're working with, a university. So those are some things to be thinking about. Then, this is something that you're going to be pacing within your community. So how much FTE can a health center support for a behavioral health care manager? So initially when you're beginning programs, you might have less FTE, smaller caseloads, but then you're maturing as a program and actually you're benefiting, say, from a psychiatric consultant. And so providers are having an easier time of identifying underdiagnosed conditions in their patients, and they're getting more comfort in prescribing medications. And so you're actually able to increase your caseloads, which would mean you then are starting to constrain some of your other resources. So then you have to think about how you're adding FTE to support those programs to actually sustain them and to continue to provide a high quality service to your patient population. And of course, you have to think about how those staff members are meeting the appropriate professional and state licensing to even build those services. In Michigan, I'll get to this, when we did have a finalized published policy for collaborative care, the licensing for the behavioral health care manager and the psychiatric consultant is a little bit more specific than what we would see with CMS for Medicare. So that's something to consider, that person, in order to bill for that service, has to meet that state policy as well. And I did go into this a little bit before, but be thinking about how, potentially doing these services is impacting your approved scope of project. And I think that certainly a case could be made for, submitting a change to that scope of project for your community as well. Next slide. So, of course, when you have this opportunity to do this work and you roll up your sleeves and you just have to do it, you uncover some things in the process. Next slide. And the biggest thing that we uncovered is the complexity around billing, of course. There's the rub. So we did uncover during this process of billing for these services that there were limitations and definitions of originating in distant sites. We certainly were very challenged by that. We certainly saw confusion among payers for certain diagnoses codes and who pays for what, whether it be Medicaid fee-for-service or whether it be the Medicaid health plan, which resulted in claims either being rejected, needing to be resubmitted, being rejected again, having low reimbursement rates, sometimes lower than 50% of what was being billed by the psychiatrist to the health center. So the main takeaway is that, this work was able to be accomplished because of grant funds to keep the health center whole so that they continue along in doing this, which leads us to our next point. So next slide. So we have been able to make some, slow and steady progress in this area. Next slide. So I'm just going to give a really high-level overview of this because I know we're closing in on the hour, and that some of the information I'm sharing for policy is current as of today, and we know how quickly things are changing. So please take most of this information as what is accurate for today. Next slide. So, of course, with seeing the changes that have come through for emergency response to this pandemic, we have seen relaxed or enhanced policy around providing, telemedicine services for the Medicare population, and, the current relaxation that we see around allowing for telephone-only services to also increase that access. And that Medicare has been reimbursing for psychiatric collaborative care since 2017 for health centers. Next slide. This is perhaps where I can really speak to the truest amount of advocacy and collaboration in Michigan, which was hard-won many years of Michigan Primary Care Association, along with our health centers and University of Michigan, even our APA chapter, working with our state Medicaid program to, create these policies for both telemedicine and collaborative care. So we actually had a telemedicine policy in draft form before the pandemic, and the pandemic certainly made that timeline speed up. So we were able to see an expansion in those definitions for originating in distant sites, which truly helps health centers and patients be able to receive timely and accessible care. Also increase the codes included for PPS. Next slide. So this is just a screenshot showing, how that is looking for this year. Next slide. Okay, and then, this is a little bit more pandemic related, so we also are seeing that there is a relaxation for telephone only visits as being part of telemedicine during the pandemic period. So we are yet to know what that's going to look like in the long term. Next slide. And again, I've spoken to this, but as of August 1st of this year, health centers are now able to bill Medicaid and Medicaid health plans for psychiatric collaborative care. Next slide. Okay, so of course we have continuing concerns to meet the needs of community and in primary care. Next slide. So of course, I can't not call out COVID-19. So experiencing the effects of this pandemic, the distress from it, this is something that is being acutely felt by our health centers, by their staff, by their communities, patients and community members alike. Many of our health centers are performing a huge volume of testing in communities and flu vaccinations and are preparing for COVID-19 vaccine. And they are offering these services to established patients and patients who, or people who are not yet patients or will not be patients. So there is a heightened need for services. We are not fully aware of what the aftershocks will be of this pandemic and, of course, how that is going to impact behavioral health care needs. So, of course, that's something that just has to remain at the back of our minds for how we continue to advocate for accessible treatment, how we are able to have nimble and flexible policy, which is something that doesn't seem to go together, and how we continue to maintain access to strong reimbursement. Next slide. So really that brings me to the summary. So thinking about how we are able to enhance the services of health centers to meet the needs of their communities. They are presenting to clinic and they have those needs. And you know what? When you start creating these service lines and you start screening, you are going to find individuals who can be referred into your programs and, supported long-term by those programs and actually get better. We know that when folks have access to timely, coordinated, and appropriate resources, we see that their health improves. So we need to have continued monitoring, system change, and advocacy. And this can really only happen by having collaboration among primary care, including PCAs, community mental health, our state medical schools, and our payers. Their payers really have to be on board as well and be aware of the changes that we're seeing in community and how that's changing the services that health centers provide. So I am going to leave it there and kick it back over to you, Don.
Thank you so much, Jackie. And I know we're on the hour. We have a couple of questions we haven't answered. And if you have specific questions for our providers, our presenters, please, type them in the box because we will get back to you. One of the questions is, and I think it was specific for you, Dr. Jones, were the medications that the psychiatrist provided available at your health center pharmacy?
Yes, we made those available at our pharmacy for increased access for our patients. So we wanted to make it easy for them to get their medication. So we added those to our formulary.
Thank you. And the other one was for you as well. It says, since you wear two hats as CEO and a direct physician provider, as a CEO, was the cost incurred justified or worth the results you saw, in your patients and as a physician?
I can say that I think that the benefits certainly outweigh the cost. Having been at this health center for over 20 years, we've seen patients that, really couldn't figure out why we couldn't really take care of their hypertension, diabetes, but yet they're sitting here with undiagnosed PTSD. So I think when we improve their mental health needs and behavioral health challenges, and it parlays over into their, primary care, and then improved health outcomes always will ultimately decrease costs. And also, just benefit the patient in general.
I think all of our participants will join me, please, in a virtual applause for all of our panelists. Thank you very much, and for the behind-the-scenes NAC team that made this webinar possible. The last slide actually is just a reminder that there are an amazing amount of resources, which you probably already accessed at the Health Center Resource Clearinghouse. The link is on the slide, and the copies of the slides will be available. In addition, each of our presenters has been gracious enough to include their email address. So if you have a specific question from them, please don't hesitate to contact them or to send us your questions, which we can then put in the frequently asked questions portion of this presentation. Again, thanks to all of you for presenting, and thanks to all of you for participating. If this were in person, I would thank you all for not smoking during the presentation. I hope that's not an issue for anyone, but if it is for you or someone that you care about, the number to call is 1-800-QUIT-NOW. Keep calm and have a super fantastic rest of your day. Thank you very much.